It's an immense pleasure to share my work with all of you today on how I tried to understand how psychological factors impact pain and disability. And so what I'm hoping that you'll get out of today's lunch webinar is the following. I'd like for you to appreciate the importance of return to work as a treatment objective for individuals. I'd like for you to understand expectancies and a bit of the science behind how they can affect trajectories of recovery, and appreciate the central role that they play as predictors of return to work following injury. And today the focus will really be on musculoskeletal injuries because that's the one that causes much of the problems for individuals and society. So talking about number of work days lost, here's a graph to show you the magnitude of the pain disability problem over the past 60 years. These aren't Canadian statistics, but we have very similar data here. And what we see is that the pain disability problem has increased considerably over time. And these are population adjusted statistics. So what we're looking at is not the number of people who report pain, but really the number of work days lost due to pain. So despite a relatively stable prevalence in terms of pain-related problems, what we see is that the disability that's related to pain continues to increase almost exponentially. And in 2015, you don't see it on this graph, but the numbers follow the trend. And this was somewhere near 300 million workdays lost in the United States. So we're in a situation where musculoskeletal conditions are considered one of the costliest non-malignant pain conditions that's currently affecting the working age population. Back pain being the main culprit, as we've just highlighted earlier. I don't know if you've heard this one before, but I think it's pretty great. There are three givens in life: death, taxes, and low back pain, because up to 80% of us will experience it at one point, and at any given time, there's at least 20% of people who are experiencing it. So the numbers are astounding, and the problem is that in the current system, we are much quicker to take someone out of work than to try and find a way to keep them at work. So I'm showing you here a graph of the proportion of people who are off work receiving compensation at different time points following a musculoskeletal injury. And these are Canadian statistics. And so what we see is that within the first month of an injury, about 50% of people return to work. After 3 months, about 50% of those who had not returned to work will now be able to return to work. However, of those who are still work disabled 3 months after their injury, only 20% of them will return to work, and the rest are likely to follow a trajectory of chronicity. After 6 months of disability, there's less than 10% chance of return to work. Now that 10% accounts for at least 80% of the costs associated with work disability. So it's a huge cost and a huge burden to society. Staying home, being off work is associated with increased social isolation, mental health problems, physical limitations, financial insecurities and dependence, stress, less participation in social activities and recreational activities, and stigma. So one might say, okay, staying home, being off work is associated with all these negative outcomes. But are there any benefits to returning to work? And our research group tried to answer this question a while back while I was in Dr. Michael Sullivan's lab at McGill. And we showed that if a person does not return to work after a pain rehabilitation program, 80% of the gains that they've achieved at the end of that program will be lost, likely to be lost within 6 months of the end of that treatment program. So return to work, is it possible? Do we want it? Yes. Symptom severity, pain, it only accounts for about 10% of the variance in return to work. Reducing symptoms is simply not enough to get someone who is off work back to work. In fact, there are studies who show that long-term work disability is associated with a host of negative outcomes that are much worse than those that I just named, like increased mortality, increased risk of substance abuse, substance misuse, divorce, and violent behavior. So what we learned with research is that what you bring to the injury, to the pain episode, really has more to do with whether it becomes persistent than the severity of the pain itself. The biopsychosocial model of pain helps us understand how different factors contribute to pain and disability. And these include medical factors, for example, a history of low back pain or age, social and environmental factors like job satisfaction, how much do you like your job, and psychological factors. So things like fear avoidance, pain catastrophizing, depressive symptoms. These are all known psychological predictors of return to work. So a big part of what I do is I try to find what makes that 10% unique. Why are they the ones who are vulnerable to developing chronic pain and being work disabled? And I want to talk about expectancies. There's about a quarter of a century of research showing that expectancies are one of the most potent predictors of health outcomes. Perhaps the most known example of the power of expectation is placebo analgesia, right? The idea that expecting pain relief from a bogus treatment will in fact produce pain relief, even more so with the help of cues and context and repetition. From research, we also know that expecting increases in pain will lead to higher pain. And in 2017, Munn and colleagues brilliantly demonstrated that pain expectations for the next day significantly predicts higher pain for the next day. Now, expectations can also affect long-term treatment outcomes, and this was demonstrated by Stéphanie Cormier and colleagues in a large study of 2,000 patients who were in multidisciplinary treatment programs in Canada. Patients were assessed prior to their very individualized treatments and 6 months later. And the single most robust predictor of return to work, of clinical improvement, and this is including pain, was the patient's expectation of improvement. So just to summarize some of the findings that the research that we know about expectancies, we know that one of the most consistent findings in experimental and clinical research is that high pain expectancies are associated with the experience of more intense pain. We know that higher pain expectancies are associated with higher pain sensitivity, and I'm highlighting here a study I published in 2019 that showed that higher pain intensities were associated with temporal summation of pain in individuals with chronic low back pain. We know that people with negative expectancies show poor responses to treatment programs that are designed to target pain, and when people do not expect to return to work, they are less likely to return to work, and I will present some data on this shortly. So my interest in recovery expectancies led to 3 studies. They're similar in terms of methodology, but they are conducted in different settings and in different populations. But because they are so similar, I'll be talking about one of them today. And all of these were conducted to try and answer this one question: do expectancies mediate the relationship between psychological variables and return to work following a musculoskeletal injury? Now, put together, all these studies looked at fear of movement, catastrophizing, depressive symptoms, and perceptions of injustice. So in one of these studies, we had 154 participants with a primary diagnosis of whiplash injury, grade 1 or 2, who were in a 7-week multidisciplinary treatment program. These people were receiving interventions from psychologists, physiotherapists, occupational therapists, and they had exercise, education, and self-management skills. In terms of demographics, our participants were 47% women with a mean age of 36, 82% reported back pain, almost 80% neck pain, and most were clerical workers, laborers, or nurses, and they were all receiving compensation from the SAQ, Société d'Automobile Québec. In the first week of their program, the participants completed self-report measures of demographics, pain, psychological variables, and then we measured their expectancies. We did so by asking them in 1 month, what is the probability that you will have returned to work? And they rated this likelihood on the scale of 0 to 100. Then 1 year later, we contacted them by email or by phone and asked them whether they had returned to work and maintained work, yes or no. I'll spare you the analyses because depending on each of the studies, we used regression analyses, bootstrapping mediations, or Tingley's R package for causal mediation. And we really always found that expectancies mediated the relationship between psychological variables and return to work. Just to reiterate, these variables were fear of movement, catastrophizing, depressive symptoms, and perceptions of injustice. And all of our analyses control for age, sex, pain intensity, duration of disability, and number of injury sites. So the results were really clear. When we put it all together, expectancies played a very central role in the context of work disability. It's like expectations were the vehicle through which many psychological variables were impacting on return to work following injury. But it's a complex problem, and the solutions are also going to be complex. Many other factors relating to, for example, the work environment or the compensation process also impact return to work. So you might have a really positive outlook on things. You may want to return to work. You may love your job. But if you know your employer is not going to make the accommodations for you to gradually return to work, or if the working environment caused what was unsafe and caused the injury and hasn't been corrected, then you will not expect to return to work, and that will be reflected in the expectancy score. So I love to use the metaphor of the regression analysis. I think that when you ask someone to rate their recovery expectancies, it's kind of like you ask them to run a multiple regression analysis in their head. We don't know which variables are going in. We don't know which ones will be taken into account, what the weight attributed to those variables will be. But regardless, the individual runs this analysis in their head and comes out with a number. And what our research has shown is that if this number is high, they are much more likely to return to work. And I've also demonstrated this more recently in a systematic review that's ready to be submitted, where we show that across many different musculoskeletal injuries, expectancies significantly predict return to work. So in conclusion, my research has really shown that recovery expectancies play a central role in the return to work process. I really think that they should be used in this context as a red flag. They indicate that something in the person's life isn't favorable to their recovery and most likely needs to be addressed. Right now, there's no intervention that's been specifically designed to modify recovery expectancies. Of course, there's a lot of work in the area of pain expectations, how to promote positive expectations, for example. But I think that the context of rehabilitation is a particular one. Sometimes the reasons for negative expectations might be very justified, not that others are not justified, but an unsafe working environment is definitely something that should be addressed. And so they require a very comprehensive view of the person's life and the challenges. So that's what I'll be looking at in my program of research at the Université de Sherbrooke. So I think that for now, the first step is really just to make the practice community more aware of the important relationship between expectations and duration of work disability and even the risk of permanent work disability. We often hear people saying that their clinician said that they just didn't think they would return to work. And so clinicians that are involved in the management of injured individuals need to be made aware of how they can play an important role in shaping expectations, because expectations are ultimately the roadmap to human behavior. So to quote my mentor, return to work is the highest level of independence that can be offered to a work disabled individual, and everyone deserves a chance at that. So I'd like to thank my research teams that I've worked with, as well as my new team at the Université de Sherbrooke and all the funding agencies who have supported my research. Thank you.